Hi everyone, welcome to our Monty Heart Grand Rounds. We have a great pleasure to have today Dr. Andrew Einstein, who will be speaking about multimodality imaging for cardiac amyloidosis. It's a great pleasure to have Dr. Einstein here today. He's a cardiologist, cardiac imager, and researcher at Columbia University and New York Presbyterian Hospital. He serves as the Director of Nuclear Cardiology, Cardiac CT, Cardiac MRI, and the Director of the Advanced Cardiac Imaging Fellowship, and a tenured professor of medicine. He's born and raised in New Jersey, and Dr. Einstein received his AB from Princeton University and then attended Mount Sinai School of Medicine, where he received an MD as well as a PhD in the Department of Biomathematical Sciences. His graduate research focused on developing image analysis methodology in microscopy. He also received an MS in patient-oriented research biostatistics from Columbia Mailman School of Public Health, and then he completed his internship and residency in internal medicine at Rutgers Robert Wood Johnson Medical School and a fellowship training at Mount Sinai. Dr. Ryan's clinical activities are centered on cardiovascular PET, SPECT, CT, and MR, and he serves on the as a attending physician staff in the Heart Institute. His research, which uses each of these modalities, focuses on improving the use of imaging in cardiovascular medicine with particular interest and current funded projects in quality of healthcare, radiation safety, global health, amyloidosis, AI, and device development. It's funded by multiple NIH grants and the International Atomic Energy Agency and industry. He has published over 300 papers and abstracts in leading journals like New England Journal of Medicine, JAMA, Lancet, BMJ, Circulation, and JACC. So it's a real honor to have you here. Thank you very much for taking the time. We're looking forward to your lecture.
Thank you very much, Leandro. Really, I've got so many friends in the audience here. I was going to acknowledge people, but there's just too many people to thank. But friends who I used to work with and colleagues who I have very high esteem of in the cardiac imaging world. So really, you've got a wealth of talent here at Monty, and it's an honor to address such an august group. So what I'd like to talk about is multimodality imaging for cardiac amyloidosis. These are my disclosures. Let's give a brief background about cardiac amyloidosis and then go through echocardiography, cardiac magnetic resonance, planar inspect scintigraphy, and PET, then talk about some artificial intelligence applications. And finally, as time permits, I'd like to share a recent study which we presented related to screening for cardiac amyloidosis. So really, amyloidosis occurs when proteins misfold, form fibrils, and the fibrils deposit in really a host of tissues potentially. They can cause protein effects depending upon where that particular misfolded proteins forming fibrils deposits. One such organ is the heart. We think about limited types of amyloidosis, but really there are about 40 or so types of amyloidosis, depending on which amyloid fibril proteins there are, ranging from cathepsins to insulin to prolactin. But really in cardiac amyloidosis, we mostly, although not exclusively, focus on two main types, or three, depending on how we count it: AL amyloidosis and ATTR amyloidosis. AL amyloidosis, the A standing for amyloid, the L standing for light chain, is a disease really of plasma cells. The plasma cells produce immunoglobulins, and in particular the light chains of those. And if those light chains become abnormal, that can cause AL amyloidosis. In contrast, transthyretin, from the word trans, meaning carry, thyro and retin, because it carries two proteins related to the thyroid and retin. is produced in the liver. And when transthyretin causes these abnormal fibroids, it can often cause cardiac amyloidosis. There's two subtypes of here. We talk about variant, aka hereditary, where a patient has an abnormal mutation in the gene carrying their transthyretin protein. And we talk about wild type, which generally occurs only in older individuals where they have a genetically normal transthyretin protein. However, it still misfolds and causes these deposits. In a little bit more detail, the final product are these fibrils, but they get there in slightly different places. In AL amyloidosis, the plasma cells from the bone marrow uh, uh, produce light chains which get misfolded and aggregate, form protofilaments, which form these amyloid fibrils, which get deposited in the myocardium. In TTR amyloidosis, the standard tetramer of transthyretin disaggregates into monomers because it doesn't get stabilized properly with TTR. These monomers misfold. They form fibrils, and these fibrils as well get deposited. The fibrils, when deposited in myocardium, cause the myocardium to get stiff, cause diastolic dysfunction to occur. Patients go into heart failure, often have arrhythmias, and that can potentially lead to death in individuals. Now, until a few years ago, we had thought that amyloidosis was really a rare condition, but increasingly we're discovering that's not the case. I think AL amyloidosis involving the heart is still rare, probably thousands of cases in the United States, but TTR amyloidosis, variant type, we probably have tens of thousands of cases, and wild type, probably hundreds of thousands of cases. You know, it's hard to put a figure on it, but somewhere in the 250,000 to 500,000 range in the United States. So this quote unquote rare disease is probably not so rare. And as both as clinical cardiologists and as imagers, there's lots of questions which we have related to cardiac amyloidosis. So let's talk about echocardiography first. Just on a standard 2D echocardiogram, there's lots of features. Oh my goodness. Welcome to the treatment center. Yes. On a standard 2D echocardiogram, there's lots of features which are characteristic of amyloidosis. We can have thickened walls, both involving the left ventricle and the right ventricle. The characteristic sparkling texture, which I learned about in medical school, I don't know if the current fellows learn about it, is not so characteristic anymore, because since we use harmonic imaging and echocardiography, you don't see that so much, although you can turn off the harmonics and still see it potentially, but we've got better echocardiographic tools. Left atrial enlargement is characteristic. Pericardial effusions are common. The mitral valve, the atrial septal can thicken. So all these things you can see on a two-dimensional echocardiogram. It's not pathognomonic for it. It's not diagnostic of amyloidosis, but it's suggestive and may prompt further workup depending upon the clinical context. I don't know if Dr. Garcia is joining us remotely, but there was great work done in the echocardiography lab, which he built at Cleveland Clinic, I guess shortly after he left, focusing on use of speckle tracking longitudinal strain patterns to characterize cardiac amyloidosis. We can determine the strain throughout the heart from the apex to the base. here using an 18 segment model of the heart, or 20 segment model of the heart rather. And you can see in the top row are 4 examples of patients in the seminal paper from Cleveland Clinic, where you see these strains are with numbers like -15, -20 towards the apex. That's normal, but if you look towards the base, strain is really reduced. And that pattern is called apical sparing, normal towards the apex, abnormal towards the base. And we give it this nickname, this cherry on top pattern, sort of like this cupcake where you've got where it's red on top, because that's where we pseudo color the normal values. But as we move more peripherally towards the basal segments, it gets really abnormal. That's distinguished from other types of cardiomyopathy, which have abnormal strain. For example, septal hypertrophic cardiomyopathy involves, appropriately enough, the septum. Aortic stenosis, there can be a more patchy pattern. And in fact, there are really a host of conditions which can have reduced global longitudinal strain related to left ventricular hypertrophy. But the one in particular which is associated with apical sparing is cardiac amyloidosis. Other conditions causing reduced global longitudinal strain will have other patterns, but this is echocardiographically suggestive but not diagnostic of cardiac amyloidosis. The British Society of Echocardiography has guidelines for echocardiographic parameters, both for diagnosis and prognosis. These are the diagnostic criteria, and you can see what they give 3 stars. Really, the most important feature, but not the only feature here, is this apical sparing pattern. But we also see the LV as well as RV wall thickening, pericardial effusion, especially in AL cardiomyopathy, elevated E to E prime by atrial dilatation, and mitral and tricuspid regurgitation all can be suggestive towards the diagnosis, but not diagnostic of. In fact, these various parameters we can also use to try to understand how late stage a patient is in cardiac amyloidosis. Factors such as left ventricular ejection fraction being abnormal, or right ventricular ejection fraction, really only occur at later stages of the game. But things like E to E prime or global longitudinal strain abnormalities being abnormal occur much earlier in the course. This is really two different case series from 2 institutions, but the findings are remarkably similar. In AL amyloidosis, staging is strongly associated with longitudinal strain. So we see as the Mayo stage goes up, the global longitudinal strain goes down in this large series of 915 patients. In terms of prognosis, if we look at the lowest longitudinal strains in the orange here, I don't think you can see my point. It's just very slow. So in the orange curves here, if you can see the lowest global longitudinal strains are associated with the worst prognosis. We can also use this parameter to assess response to therapy in AL amyloidosis. So there's lots of information which can be gleaned from the echocardiogram, and it's been proposed to even include this in the staging of AL cardiac amyloidosis. It's not the only prognostically useful parameter. Simple measures such as cardiac output and the presence or absence of pericardial effusion have important prognostic information as well. Let's move on and discuss cardiac magnetic resonance. So this classic paper from 2005 from the Royal Brompton Group really first gave us information which we use to this day to talk about cardiac amyloidosis on MRI. You can see this global subendocardial late gadolinium enhancement in the image on the lower left here. And what's also seen is abnormalities in the kinetics of myocardium and blood pool gadolinium uptake. It's a classic pattern, probably better illustrated in this more recent paper. One of the pulse sequences which we obtain whenever we're doing late gadolinium enhancement is something called a TI, or inversion time scout. And we look at subsequent values from lower to higher values of a parameter called the inversion time, which we use to try to null the myocardium, turn that myocardium black, in which case things that appear white in that myocardium is late gadolinium enhancement. And when we do that in normal cases, the blood pool generally nulls at a lower inversion time than does the myocardium. You can see that in the bottom row. In amyloidosis, however, sometimes it's very hard to null the myocardium, and in other times, the myocardium will null at a lower or the same inversion time as the blood pool does. That's abnormal, and that's a pattern that's characteristic of late gadolinium enhancement. Combined together with either a subendocardial or transmural late gadolinium enhancement, in hypertrophied myocardium, that's quite a strong predictor, although not formally diagnostic, of cardiac amyloidosis. In fact, in this study, the authors tried to see what the sensitivity and specificity of both a late abnormal gadolinium kinetics, this typical late gadolinium enhancement pattern, and the absence of light change suggestive of AL amyloidosis was. And they found a 73% sensitivity and 98% specificity for the presence of transthyretin cardiac amyloidosis. Pretty good, but not quite sensitive enough for this to be our definitive diagnostic test. And that's why there's lots of information which we can glean from cardiac magnetic resonance. It doesn't serve formally, except in some circumstances, as the diagnostic test for cardiac involvement in amyloidosis. Another thing which we consider is a series of techniques called parametric mapping in cardiac magnetic resonance imaging. In particular, we look at something called T1, which is associated with myocardial fibrosis. What's the physics of T1? Very basically, it's the time after which a tissue's longitudinal magnetization has returned to 63% of its original value after we've applied an inversion or a saturation pulse in cardiac magnetic resonance imaging. We often talk about Look-Locker sequences because this was developed by Dr. Look and Dr. Locker back in 1970. It was really only first measured in human hearts 15 years later. And the sequences which we use now most commonly, there are others, but these are the most common, are called Mali and shortened Mali or Schmali, which are modifications of this Look-Locker inversion recovery. So if you see at the upper right, when we see a high T1, that can be associated with a number of conditions, including hypertrophic cardiomyopathy, myocarditis, and amyloidosis. And a low T1 can occur in conditions such as Fabry's disease. Closely related to T1 is something called the extracellular volume fraction, or the ECV. And that's done by obtaining T1 values in the myocardium at baseline, and then after we've administered a gadolinium-based contrast agent to the patient. We need to know what the patient's hematocrit is, and Then we use this formula to calculate what that ECV is. Again, what that fraction is. So when there's interstitial fibrosis, T1 is elevated. When there's more interstitial fibrosis, for example, in scar, T1 is even more elevated. And generally, when we just look at T1s, we're talking about the native, that is the pre-contrast T1. When there's interstitial fibrosis, you have elevated ECV, but you don't typically have late gadolinium enhancement, or you don't have so much late gadolinium enhancement because it's not that so many of the cardiomyocytes have been replaced by fibrous tissue, so that gadolinium can still get back into the cells and transported away. But when there's a lot of fibrous component, the gadolinium sticks around, and you can see both a very high extracellular volume and late gadolinium enhancement here. So we can apply this to the problem of cardiac amyloidosis. In this study, you can see 3 patients in the upper left panel. In the first patient, there's no late gadolinium enhancement, and the T1 value is 1,054 milliseconds, and the extracellular volume fraction is 28%. In the second patient, there's subendocardial late gadolinium enhancement. I don't think, yeah. So you can see that here. The T1 is elevated just a little bit, but the ECV is up to 40%. And then in the third patient, you've got transmural late gadolinium enhancement. T1 is more elevated, and the ECV is up to 63%. So by using this ECV, we can characterize the amount of cardiac involvement in transthyretin or AL cardiac amyloidosis. And in general, this relationship progresses. When there's a higher ECV, you can have subendocardial late gadolinium enhancement. When you have a very high ECV, you can have transmural late gadolinium enhancement. And in fact, there's a significant difference in survival for patients with very high ECVs versus not so high ECVs. So here you can see the Kaplan-Meier curves comparing ECV of less than or greater than 58%, and there's a big difference in cumulative survival in these patients. And in fact, in a multivariate model, it's really the most important imaging finding. So if you compare E to E prime is not significant when you adjust for everything else. But left ventricular ejection fraction, even in this study of 341 patients, isn't significant when you control for everything else. LV mass isn't, but ECV is. Each 3% of increase in ECV was associated with a 1.164 hazard ratio of death in patients. Now, ECV can be used to follow response to therapy. So here's an illustration with treatment with an agent called patisiran. We'll talk about different therapies in a bit. And you can see a 4-chamber view and 3 subsequent short axis views at the basal, mid, and apical levels. And you can see more dark blue in the bottom row. The top row is baseline. The bottom row is a month after treatment with patisiran. And in general, if you compare treated patients, ECV didn't change in this study. Untreated patients, ECV progressed over the course of a year. So but by virtue of giving patients these therapeutic agents, we can measure response to therapy with ECV. In addition, ECV can be quite useful in looking at rare types of cardiac amyloidosis, even for diagnosis. So here's a recent study from the National Amyloidosis Center in London, looking at patients with apolipoprotein A1 and A4 cardiac amyloidosis. And you can see, particularly in A1, there's characteristic right ventricular late gadolinium enhancement and abnormalities in ECV. So in these patients where they're scintigraphically negative, you can have abnormal findings on cardiac MRI. So MRI can be very useful in these circumstances. So where can one use CMR in amyloidosis? It's not for routine diagnosis, but for presentations which are suggestive of other infiltrative processes. If you want to tease apart hypertrophic cardiomyopathy and amyloidosis, if there's concern for a rare amyloidosis type like the ApoA1 or A4, for an evaluation in the setting of a known plasma cell disorder where AL is more likely and scintigraphy may be negative, for evaluation of a known carrier of a mutation in the transthyretin gene, for follow-up of an equivocal nuclear scan, and possibly for response to therapy as well. But really, the single modality which is used the most diagnostically for cardiac amyloidosis is nuclear imaging. This was first developed with planar imaging, then extended to SPECT and SPECT CT. But you can see per these multi-societal guidelines, the diagnosis of cardiac amyloidosis can be with endomyocardial biopsy or a clinical diagnosis using scintigraphy with bone-avid agents. Really, there are 3 agents which one can use. 2 of them are approved for use in the United States. Those are technetium-99 pyrophosphate and technetium-99 M-oxidronate, otherwise known as hydroxymethylene diphosphonate, aka HMDP or HDP. All those latter ones are the same. So 3 names for the same drug, which is a little bit confusing. Tech 99M DPD is used in the United Kingdom and many parts of Europe widely. It's not cleared for use in the United States, but we use this 4-point grading system where we compare to bone, being no uptake, uptake less than bone, uptake equal to bone, and uptake more to bone. Those are respectively grades 0, 1, 2, and 3. We call those the Perugini grades based on the first author of the classic Jack paper for that. And we can look at that on both planar and SPECT imaging. Another technique, which was actually developed at Columbia, is to calculate on planar images a heart to contralateral ratio. And when we looked early on, use of a heart to contralateral ratio of greater than 1.5 on 1-hour imaging had 97% sensitivity and 100% specificity. So kind of we're done, right? It's such a good diagnostic test. But I think, and this is one of my favorite papers in all of medicine, and it dates back to the 1970s from David Ransohoff and Alvin Feinstein, talking about problems of spectrum and bias in the evaluation of the efficacy of diagnostic tests. We have a new test. And we try it out, and it's fantastic. And why is it fantastic? Because we're comparing like healthy young people to people with like older people with myocardial infarctions or something like that. So if you have such stark differences between populations, it's easy for a test to do what it's supposed to. But then the test becomes popular and you start using it more, in the spectrum of patients in which you're applying it changes, and you're looking at different things, and then suddenly our new test is not so great. And that's exactly what happened in the world of amyloidosis. The largest study of bone-avid scintigraphy in in amyloidosis is this study from Julian Gilmore looking at about 1,200 patients. And if you look in the lower left here, you can see of their 1,200 patients, there were over 100 patients who had cardiac amyloidosis, from biopsy or whatever, who had Perugini grade 0, and over 100 more patients who had Perugini grade 1. And usually we draw that line between 1 and 2. So it's not such a perfect test, and hence we have need to do more. I think one of the reasons why it's negative is that there are two types of transthyretin amyloid fibrils. We call these creatively type A and type B. On Western blot, type A manifests as a mixture of full-length transthyretin and C-terminal transthyretin fragments, and type B are full-length TTR. If we stain with Congo red and examine under polarized light, type A has a weak affinity for Congo red and green birefringence, whereas type B has this strong affinity and has a brighter and glittering green birefringence, which you can see between the red areas here. Now, type B is only in 4 variant types. Val30 MET, Phe64 Lu, Glu74 ASP, and Tyre114 cis. Of the 130 or so mutations which can occur in the transthyretin, only these 4 are type B, and it happens to be that bone avid scintigraphy is not such a great test for these patients. Here's an illustration. 38-year-old Portuguese man with a Val30 MET mutation. He had neuropathic pain, sensory defects in his feet, carpal tunnel syndrome. He got admitted to the hospital with syncope, had a first-degree block, left bundle branch block, LVH, decreased global longitudinal strain, and the longitudinal function was decreased, especially in the base, i.e. our cherry on top pattern. His EF was mildly reduced at 48%. His ECV was mildly increased at 40% here. And you take a look at his bone scintigraphy, and it's negative. Now, on the planar images here, you're not seeing uptake in the heart. When you're looking at the SPECT-CT fusion images, you're just seeing uptake in the blood pool here, but not in the walls of the myocardium. Negative scintigraphy, but positive everything else. You see the subendocardial late gadolinium enhancement here. Everything we've talked about with the other modalities, positive, scintigraphy negative, and that's because it's this Val30 MET, this type B fibrils. And there's a couple of papers focusing on this. And in this one paper, 97% of patients with type A and none of the patients with type B fibrils had DPD uptake at scintigraphy. In the other paper, in JACC imaging, the sensitivity of bone scintigraphy in detecting TTR was 10.5% in Phe64 Lu. So you're just not detecting it. So it's the wrong test for patients who have this mutation. But going into it, you don't know which mutation the patient has. You haven't sequenced the gene yet. You don't even know that the patient has the disease. So it's not a perfect test. So bone average tracers are good. Sensitivity 97%, specificity 100%. No. We've learned more. They're pretty good for TTR, but they're not good for AL. We don't know how they work even. We hand wave to a certain degree. We talk about microcalcifications, which they pick up on, maybe binding circulating amyloid P component, but we don't really know how they work in amyloidosis. Here's the classic Perugini paper, which that scoring system comes from. And if you take a look at the patients with AL cardiac amyloidosis, there's just not much. So there are a few patients in whom you had increased signal, but in general, you're not picking up the AL amyloidosis patient. So we need better tracers. So what's missing? Improved accuracy for TTR amyloidosis, a sensitive tracer for type B fibrils, a sensitive tracer for AL cardiac amyloidosis, earlier detection of disease, and the ability to track disease progression in response to therapy. Not seeing it. I don't know why we haven't advanced here. I'm not quite sure why. But
You
it's,
want to exit it?
yeah. Oh, okay. That was easy enough. Okay. Great. Oh, this happened before as well. Share screen. Sorry about that. Entire screen, and it's not giving me the entire screen. I can share this. Problem with this is, we can live with this, I think, right?
You want to try sharing this?
I can try this.
No, we can leave it at
Okay. We can live with this. Okay. So there's a lot of information on this slide, but we've got lots of therapies for amyloidosis now. We can divide them into, I don't know. So there's lots of therapies. We can divide them into three categories, say silencers, stabilizers, and degraders here. Silencers are really the first drugs which have come to market. And basically, I'm sorry, stabilizers are the first drugs which have come to market. And basically, that's in the middle here. Each of them works in a different area. So you can silence it at the level of the liver, right? Don't make new stuff. You can stabilize it by stabilizing that tetramer at the level of the tetramer, which has already been produced. And you can degrade it at the level of the deposits in the heart or whatever organ it's involved with. So the drug which we've all been using for the past couple of years now is tafamidis. Could you get this to work for the full screen mode, or?
just takes a little. Because there isn't. It's not trying to do it with the other side.
I make the executive decision that for the sake of time, let's just continue in the imperfect mode. Okay. Okay. So tafamidis is a stabilizer. It stabilizes that tetramer. There's another drug which was just approved by the FDA. I don't think we're clinically able to get patients on it quite yet, and that's acoramidis. And then there's an old-fashioned non-steroidal called diflusanol, which is like a tiny fraction in cost of the other drugs, but it's got a worse side effect profile. So it's really a drug of last resort, and those are our stabilizers. We've got a different class of drugs which are silencers, work at the level of the liver and silence or inhibit TTR synthesis. Patisiran is the drug which we looked at before. Happens to be there was a nice clinical trial of patisiran but the evidence wasn't overwhelming there, and the FDA decided we're not going to approve it for cardiac use. So while it's approved for polyneuropathy in the setting of amyloidosis, it's not approved for cardiac amyloidosis. So that gets the red box around here. It's you're not going to get it paid for your patient. But there's another drug called vutrisiran, which had a nice phase 3 clinical trial as well. And I think by the end of 2025, we should see vutrisiran on the market. So instead of just having tafamidis, we're going to have tafamidis, acoramidis, and vutrisiran on the market. So that's already 3 drugs, which we'll have by the end of this year, which we can use in patients. And then there are even more exciting approaches using maybe even a single injection of CRISPR-Cas to edit the gene for transthyretin amyloidosis. So like a one-time therapy to inhibit that TTR synthesis. And then we've got antibodies, which potentially can remove your deposits from tissue and reverse this process, not just stabilize it. So there are a number of these. We're involved at Columbia in most, but not all of these trials. I would imagine you guys are involved in numerous of these trials as well. But we've got really a host of drugs, and we need to follow, like, how do we know that a drug, and these drugs can cost upwards to $500,000 per year, is working, or if we want to compare between 2 drugs. So we really need something that's quantifiable and measurable. ECV may be an approach, but better nuclear imaging methods, I think, are going to be really indispensable. And there are a number of PET tracers with more amyloid-specific binding, which are being investigated. 4 of these drugs are based on thioflavin, which was identified in 1959 as a fluorescent stain for amyloid. It binds along the surface side chain grooves running parallel to the long axis of the beta sheets. And there are 2 thioflavin T derivatives, which are radio-labeled. The first of them, which was introduced, I don't know, 30 years ago or something like that in Pittsburgh, is C11 Pittsburgh compound, and there's F18 flutometamol. And then if you add a tail to these are a class of drugs called stilbenes. And these include agents like florbetaben and florbetapir. But what's excited people the most recently, and something which we've been working a lot with, is a drug called I-124 evuzametide, which has gone by a couple of other names as well. I think we lost a little bit of time, so let's skip discussion of the thioflavin derivatives and stilbene derivatives and jump ahead to evuzametide. This drug works basically on the following concept. Their heparan sulfate proteoglycans are components of amyloid deposits, and you can have a peptide which binds heparan sulfate proteoglycans, and you can radio label that, and in principle that should radio label wherever you have amyloid deposits. So there's a very smart guy at the University of Tennessee by the name of Jonathan Wall, who's really built his career around this, and he looked at 7 specific peptides and looked, and he I think this was funded by an R01 from NIDDK. So he was especially interested in like a pan amyloid imaging agent, because he wanted to image the kidneys as well as the heart. So he looked at these 7 peptides, and he looked for something with a good heart signal, but also a good kidney signal. So it may not be like the highest uptake in the heart, but it's good in the heart, and it's good as a pan amyloid imaging agent. He radio labeled it with I-124 at this time, and used it in a mouse model, and picked one of these. That was called P5. And then he played with P5 a little bit more. He added 14 additional amino acids with additional positive charges, which gave it increased affinity and extended amyloid reactivity. It has this alpha helical structure, and because it was P5 with 14 additional amino acids, it became known as P5 plus 14, and that got radio labeled. Then a company called Atralis started developing it, and it became AT01, and then finally got a formal generic name. So now it's called evuzametide. So this was the first in human case, and this is only from 3 years ago now. This is from the Tennessee group looking at their first case with it. This was our first case at Columbia, which was from shortly after that. It was a 64-year-old Black male diagnosed with hypertrophic cardiomyopathy, but who had a V122I under the new nomenclature system, V142I genotype for transthyretin amyloidosis, but had a negative PYP scan. So you can see his echocardiogram. He's got this LVH, he's got RVH. You know, I don't know. His valves look a little bit thickened. You can see his PYP scan. There's not heart uptake, but he had a positive endomyocardial biopsy. You can see on the Congo red staining here. Then we imaged him with evuzametide, and you can see he really has uptake in his heart. So PYP, it failed this patient, but evuzametide, it was positive. We think that this picks up a weaker signal, picks up things earlier in the stage of the game. So Jonathan conducted a phase 1/2 clinical trial of I-124 evuzametide, 25 patients. He gave them 2 millicuries each. Cardiac uptake was seen in 16 of 25 AL patients and 17 of 20 ATTR patients. The sensitivity in those who had been previously diagnosed with amyloid was 93% in AL and 100% in ATTR. Remember, the bone avid agents don't work well in AL. And cardiac uptake here was noted in 11 patients who hadn't been previously diagnosed with disease. And then there was no cardiac uptake in the 5 healthy subjects here. So it seems like it's a good diagnostic test. This is work from the Brigham group. Olivier Clerc compared it to florbeta-pir, which is one of the stilbenes, and it seems to be better by most metrics. It's got a stronger signal than does florbeta-pir in these individuals. But notably, the study only looked at wild type. It didn't look at variant. So with my colleagues Dia Smiley and Matt Moorer, we've looked at 25 patients as well who we've imaged. 7 of them have had wild type ATTR, and 18 of them are variant allele carriers. And we found 11 patients who had Perugini grade 0 or 1 PYP scans had cardiac uptake of evuzametide, indicating transthyretin cardiac amyloidosis. All 7 subjects with grade 2 or 3 scans had concordant cardiac uptake of evuzametide. We showed uptake in all 5 variant TTR subjects with biopsy-proven disease, and 2 subjects with wild type TTR and negative PYP scans, but extra cardiac biopsies showing TTR. And then myocardial amyloid loads, correlated nicely with disease stage and echocardiographic and quality of life measures. So you can see those here. As an okay. These are the correlations with measures of amyloid load with troponin, echo parameters, BNP, Columbia score, and Kansas City Cardiomyopathy Questionnaire score. As an illustration of one of our cases here, you can see a patient with the 360 isoleucine mutation. The planar image was grade 0 or 1. If you look at the SPECT CT images, that you're just not seeing much here in the middle column, but if you look at the right, it's clearly positive by evuzametide. So we're really excited about this compound. Nevertheless, it's not perfect. Because you're giving patients iodide, you uh, give the patient 124 to limit radiation exposure to the thyroid that could result from the formation of free I-124 in their thyroids. I-124 has a half-life of 4 days, so it sticks around for a long time. So it's high radiation from that, relatively 9 millisieverts per millicurie. So we can only give 1 millicurie, which means it can be challenging to image. And if you want to serially image patients, that dose can add up as well. There's a long delay between injection and imaging, and manual analysis can be challenging. Our manual analysis, we use a nuclear medicine program called PMOD here. It takes maybe an hour or so to analyze a case. So for all those reasons, I'm not sure if it's ready for prime time. It's in a phase 3 clinical trial. We're part of that clinical trial, but it's got its pluses and its minuses, but it's definitely a more sensitive test than is bone avid scintigraphy. So because of the difficulty in analysis, we turned to a mutual friend, Piotr Slomka, and we've been using AI techniques to automatically quantify evuzametide uptake in our patients. And basically, we automatically segment the different chambers of the heart, and we can look at target to background ratio, look at SUVs and other relevant parameters to characterize things. So you take a look here, the target to background ratio is 5 and the SUV is 8 in this patient with amyloidosis, and in this patient with here's another patient with it, but it's more localized disease, which you very well could miss on a PYP scan. This could be early disease just developing in the lateral wall. So no imaging tool is perfect, but this may be the most sensitive thing we've got. So that's not the only AI application which we have for looking at amyloidosis. But there are really a number of things. We can use it for segmentation and quantification in PET CT. We can also use it for quantification in SPECT CT. We can diagnose amyloidosis on echocardiograms. We can get a virtual ECV from native T1 images and thus avoid the need for contrast. And maybe we can estimate hematocrit as well to make cardiac MR more simply. And we can screen electronic health record system for patients with undiagnosed amyloidosis. So here, using similar methodology, also from the CEDARS group, is AI-based SPECT CT analysis of PYP scans. Monty and Columbia will both be part of a multi-center registry, which we're developing for this. But you can see the images are not as crisp as these PET images we had, and probably not as sensitive. Can diagnose amyloidosis from echo images here. And you can see in this study from David Ouyang's group, the most important features here were included global longitudinal strain as well in this AI model. So same ideas keep percolating. Here's another study with high throughput precision phenotyping of LVH with cardiovascular deep learning. We can do virtual non-contrast ECV using AI, and you can see the strong correlation with virtual ECV versus ECV. The difference is the virtual ECV we didn't give, or it's determined based solely on the native T1 images, not on the contrast images, although this still required the use of a hematocrit obtained within 48 hours or so. But there's other literature, and all this junk in the background you wouldn't see if the slides were working properly. I apologize. But there are equations which people have developed to estimate what hematocrit is based on regression equations. So I think cardiac MR is going to get simpler, and we may be able to do it like a really quick MR with no contrast and native T1 mapping in 15 minutes in principle, and estimate an ECV from that. So that may be a useful tool for tracking all these great new therapies which we have to consider. And finally, I'll talk about work which I'm doing together with my AI colleagues, Pierre Elias and Tim Podoruca, is looking for patients with hitherto undiagnosed cardiac amyloidosis just by screening the electronic health record. So if we look across the NYP system at the rate of PYP positivity, it's about 14% in 2023. So we do, what is that, like 7 PYP scans to pick up one case? Huh? Same in the Monty system as well. But we've developed this AI-based algorithm to screen go through the EHR, look at patients' clinical characteristics, look at their ECGs, and look at their echoes and say, hey, this patient has a high probability of having amyloidosis. Doctor didn't pick it up, but just what we can see in the EHR, this patient may have it. So we've done a pilot trial in the first 3 months of the 21 patients who we referred for PYP scanning. 11 of them have actually had amyloidosis. That's a 50% pickup rate. So there's a lot of these patients who are there who are just not picking up amyloidosis, but they've got it. And many of these patients are going to die of amyloidosis. You know, people will think it's old age, they got short of breath, but really they had undiagnosed amyloidosis, and we can pick it up by using doing better things with our resources. Hopefully there'll be a full presentation of this at ACC this upcoming year. So with that, hi, so what Carlos, an old friend from Colombia, points out is we can't diagnose what we're not looking for. So we got to look for these, and I think that's a good message. Let me skip the screening stuff and conclude with a few words about the future of cardiac PET. For amyloidosis, I think really what we need is high accurately diagnosis for TTR amyloidosis, both types A and B. Maybe evuzametide or something like that will give us that. High accuracy diagnosis for AL amyloidosis, early detection of disease and initiation of therapy. We need multi-parametric quantitative automatic tracking of disease progression, be that with PET imaging or ECV or virtual ECV. We'll have to figure out how to do that. Quantitative automatic tracking of response to therapy and prognostication using multiple additional AI tools to enhance patient care. We'll screen in selected patients. One thing which we found in the SCAN-MP study in Black males over the age of 75 enrolled in this study, we found a 17.5% rate of undiagnosed transthyretin cardiac amyloidosis. So there's lots of these populations and patients in the general population who have it, and we're missing out on it, and they're dying because of this. So using AI tools, I think, will be critical in the future, and we'll screen in these populations, and ultimately we'll have imaging driven optimization of therapeutic regimen, especially as the therapeutic choices for both TTR and AL get more and more complicated as the years go on. So I think the future is bright for cardiac imaging in cardiac amyloidosis, but it's going to take a lot of work in the years ahead. With that, I'll stop and Good.
Thank you very much. That was an amazing lecture, and it just shows how specific we're getting in imaging and how we need to have imagers dedicated to specific areas. This was amazing. So please put your questions in the Q&A. We'll go through them.
I think the only way to see that maybe.
Any? Here. Yeah, perfect. Any questions from here? Yeah, I can try.
Is that turned on?
No, no. Turn it on. Yeah.
Thank you for that.
You're welcome.
Just repeat the question.
I will repeat it.
I just wanted to ask you, you show a nice case of type B TTR amyloid that wasn't picked up with nuclear imaging. Have you seen the other way around? MRI in negative and the positive nuclear scan for amyloid?
MRI being negative and a
no
positive.
in MRI, but a positive PYP or nuclear.
It's kind of a complicated question because often we're not getting all the modalities in the same patients. We try to avoid layered testing. That being the case, some patients benefit from it, but you definitely have patients for whom an MRI, it's not really a positive or negative test. So you can have patients without late gadolinium enhancement for sure, for whom you have uptake on bone avid scintigraphy. Often those patients will have mildly elevated ECV, for example. So there's a tendency to binarize these things, but it's more complicated than that. And there's early stage disease, which you may have hintings of in one modality or another modality, but it's hard to say yes and no in two different modalities.
From Dr. Jordi.
So great talk. Hope they can hear me. I have two technical questions. One, the ECV. Do you think that 1 month after gene silencing therapy, the ECV could change, i.e. phenotype changes? That could be a yes or no answer. And the second question is very relevant to us in the Bronx here. You did show the mutations that are PYP negative. V122 was not one of them, I think.
That's correct.
And obviously that's a very common mutation.
That's the most common
Yeah.
that we see in the United States. I think 3 or 4% of American Blacks
3.4.
have it.
Yeah, 3.4%.
Yeah.
So is that, because that was your example case with the negative PYP scan.
Yeah.
You
So
wanna-
that patient, I think, was more early stage disease. That the PYP was not yet positive, but if you did a PYP on that patient, you'd pick it up 2 years later. Exactly. Specifically on V122I, Matt Maurer and I are co-investigators on a grant led by Justin Groden at UT Southwestern, where we're looking at family members of people with V122I, and we're doing cardiac MR in all these people and looking at ECV. So the question is, can you pick up fruiform disease or not even, like, how do you define disease even? But are there abnormalities in ECV, but it never manifests itself as heart failure in these patients? Those are the kind of questions which we're trying to ask. So again, it's not a yes or a no thing, but ECV may be a powerful tool. In terms of your first question,
how long would it take?
Yeah, the problem with silencers is precisely that. They silence it, but if already you have deposition in the heart, I don't know if you're going to see regression. And if you saw in that one study, the patients who were on patisiran, it's the ECV stabilized over 12 months, like the delta averaged 0, whereas in the patients not on patisiran, it increased by a few percent. So I don't think you're going to see regression of ECV. With these monoclonal antibodies, maybe you will. For patients with who've had disease for a while, it may be the depleters which are the most effective, even more so than CRISPR-Cas. You may and probably the future, it's going to be like oncology. Probably there'll be combination therapy. You're going to they're symptomatic. But how do you sort of measure all these things? And I think we need all the tools we can get. The decision for anti-coagulation. I think in the absence of known atrial fibrillation, most people would not anti-coagulate patients. But we're not constant, like maybe we'll be able to measure left atrial activity like we do on these evuzametide scans with Piotr Slomka. We do segment out the left atrium. So if you can see a thick-walled left atrium where you can actually see evuzametide uptake, maybe, and we can correlate that to subsequent development of atrial fibrillation. If the patient doesn't have a device, maybe there could be a case to be made for prophylactic anticoagulation, but we need more clinical trials to really establish that. So I think in 2025, there's not much of a role for it, but I could see in the future having a more sophisticated approach and for stroke prevention in some of these patients. But it's going to take maybe further development of these diagnostic tools and clinical trials based on them to be able to do that.
Thank you very much. And speaking of atrial fibrillation, last question from Luigi Di Biase.
I want to ask about the ventricular arrhythmias. So thank you for your beautiful lecture. There is controversy here. So when in patient with diagnosed amyloid, you would consider ablation of ventricular arrhythmias, and what's the role of the ICD? Because there is controversy about the prophylactic use of ICD in this patient. What's your personal opinion on it?
I think it depends on the patient and the burden of ventricular arrhythmia. It depends on their left ventricular function. So I think that decision, it's not so clear cut. And even, like the so-called clear-cut decisions we make for patients with ischemic cardiomyopathy may not be so clear cut, and all the more so for non-ischemic cardiomyopathies. There's a meta-analysis published in JAMA in 2024 looking at defibrillator therapy in patients with non-ischemic cardiomyopathy, and EF wasn't really the critical factor. I think burden of late gadolinium enhancement actually is maybe more important than ejection fraction there. So I think we need better radiomics or imaging biomarker studies to understand which of those patients are really at risk of lethal events and warranting the defibrillator, and which patients aren't. Certainly in 2025, for a patient with normal left ventricular systolic function, who's not like an survivor of sudden cardiac death, not an avid cash or SIDS patient, even with amyloidosis, we're not going to put a defibrillator in.
Yeah, let's closing, make a push for our meeting.
Yeah, so we're closing with this. Thank you very much. And we have one comment from Dr. Jordi to end the lecture.
Yeah, just amazing lecture. I just want to make a pitch for our symposium next week at White Plains in the evening on amyloid, January 15, if those of you who are listening can attend. And to underscore Andrew's point to the increasing importance of amyloid, there are 500,000 African Americans in the Bronx. 3.4% is about 70,000 will have the mutation. And then you can discuss penetrance, and even if you say very low 10%, there are over 1,000 variant cardiomyopathies in the Bronx. And we have a new initiative to try to find them, and we'll do it together with Columbia, I guess.
That would be great.
Thank you.